Bronchiectasis. Definition: pathological dilation of the proximal and medium-sized airways from weakening or destruction of their walls. Causes: primary infections, bronchial obstruction, aspiration, cystic fibrosis, primary ciliary dyskinesia, allergic bronchopulmonary aspergillosis, immunodeficiency states, congenital anatomic defects, connective tissue disorders, alpha-1 antitrypsin deficiency, autoimmune diseases, idiopathic inflammatory disorders, autosomal dominant polycystic kidney disease, traction from other processes, and toxic gas exposure. Types: as per Reed, 1950, cylindrical dilated bronchi with straight and usually regular outlines, tram track lines parallel to each other, and signet ring shape can be seen when we see in the axial plane. Here the tram track sign and the signet ring sign. Cystic. Another type is cystic. Ballooned appearance of bronchi may have air fluid level, large cystic area with a honeycomb appearance, thicker than bulla of emphysema. Here we can see in X-ray and even in CT scan the honeycomb appearance. Varicose. Third type is varicose. Bronchi with dilated segments and other areas of constrictions, beaded bronchi. We can see beaded, pearl like. Signs and symptoms: cough with mucopurulent sputum, which can be seen daily, which lasts for months to years. Hemoptysis means blood in the sputum, which generally indicates toward the acute infections. Dyspnea, pleuritic chest pain, wheezing, fever, weakness, fatigue, and weight loss. Sometimes dry bronchiectasis can be seen with episodic hemoptysis with or without sputum. Exacerbations of bronchiectasis from acute bacterial infections may lead to increased sputum production over baseline, increased viscidity of sputum, a foul odor of the sputum, which can be seen occasionally, low-grade fever, which is rare, increased constitutional symptoms like fatigue and malaise, increased dyspnea, shortness of breath, wheezing, or pleuritic pain. Diagnosis: history and complaints, daily cough and purulent sputum production, sputum analysis, chest radiography, high resolution computed tomography. Scanning is the gold standard test for diagnosis, means CT is gold standard. Finding on physical examination are non-specific and may include the following: crackles, rhonchi, scattered wheezing and inspiratory squeaks on auscultation, digital clubbing, cyanosis and plethora, wasting and weight loss, nasal polyps and sign of chronic sinusitis, physical stigmata of cor pulmonale in advanced cases. Tests to identify underlying illnesses include the following: quantitative immunoglobulin level to exclude hypogammaglobulinemia, quantitative serum alpha-1 antitrypsin level to rule out alpha-1 antitrypsin deficiency, aspergillus precipitans and serum total IgE levels to diagnose ABPA, autoimmune screening tests. Differential diagnosis: alpha-1 antitrypsin deficiency, aspiration pneumonitis and pneumonia, asthma, bacterial pneumonia, bronchitis, chronic obstructive pulmonary disease, cystic fibrosis, emphysema, GERD, parapneumonic pleural effusions, and empyema thoracis tuberculosis. The anatomical distribution of bronchiectasis may be important in helping diagnosis any associated condition or causes of bronchiectasis, which are as follows. Bronchiectasis as a result of infection generally involves the lower lobes, the right middle lobe, and the lingula. Right middle lobe involvement alone can suggest right middle lobe syndrome, an anatomic dysfunction, or a neoplastic cause with secondary mechanical obstruction. Bronchiectasis caused by cystic fibrosis, Mycobacterium tuberculosis infection, or chronic fungal infections tend to affect the upper lobes, although this is not universal for cystic fibrosis. Allergic bronchopulmonary aspergillosis (ABPA) also affects the upper lobes but usually involves the central bronchi, whereas most other forms of bronchiectasis involve distal bronchial segments. Management: antibiotics and chest physiotherapy, mainly bronchodilators, corticosteroid therapy, dietary supplementation, oxygen reserved for hypoxemic patients with severe disease, hospitalization for severe exacerbations, surgical therapies. Acceptable antibiotic regimen for mild to moderately ill outpatient include 7 to 10 days of any of the following: amoxicillin, tetracycline, trimethoprim sulfamethoxazole, a newly macrolide like azithromycin or clarithromycin, a second generation cephalosporins. Nowadays third generation cephalosporins are used, a fluoroquinolone. For patients with moderate to severe symptoms, parenteral administration of following antibiotics may be indicated: an aminoglycosides, gentamicin or tobramycin, and an anti-pseudomonal synthetic penicillin, a third generation cephalosporin, or a fluoroquinolone. Tobramycin for patients infected with mucoid Pseudomonas species. American Thoracic Society recommendations for treatment of Mycobacterium ovium complex (MAC) infection in the setting of bronchiectasis are as follows: combination therapy with clarithromycin, rifampicin, ethambutol. Consider streptomycin as a possible fourth drug. Continue therapy until the patient's culture results have been negative for 1 year. The typical duration of therapy is 18 months to 24 months. Surgical resection of involved bronchiectatic sites is an important adjunct to therapy for patients with focal disease that is poorly controlled by antibiotics. Other indications for surgical interventions are reduction of acute infective episodes, reduction of excessive sputum production, massive hemoptysis, alternatively bronchial artery embolization may be attempted, foreign body or tumor removal, consideration in the treatment of MAC or Aspergillus species infections. Some important points are: first, described by Linneck in 1819, most often occur in association with systemic illnesses such as cystic fibrosis, pulmonary disease, or both. Abnormal dilation of the proximal and medium-sized bronchi, generally more than 2 mm in diameter. That's all.